I'm just adding people to the stage. Some people are probably getting dropped off as it comes through. Bear with me. We'll just keep adding people as we go through. But I will start because given the nature of the time and the investment of time that everyone's put forward into this, which I thank you all for that, I think it's worthwhile us starting now. Just getting Fiona Trad lined up. Hi, Fiona. Can you hear us?
I can. Sorry, I had tech difficulties, Brad. I can hear you. I just can't get my camera working for some reason.
Oh, that's okay. We hopefully we can see your presentation as you go through. What we'll do, I'll get started, and then as we go, I'll just add different people as they come up. So I want to welcome everyone to this Aged Care Forum. As per the invitation, we're here to discuss resident patient client workflows through, and we've organised a couple of different speakers, but just an introduction on who we are. I've met some of you, and some of you I have not met before. So I'm Brad Sandlands. I'm from Quality INSITE, and we have been working closely with aged care providers, Metro North and Metro South, in a project around communication portal device that comes through from the hospital network into the aged care providers network. So I'm joined by Lisa Goff, who's on camera. Lisa is our operations manager and is our process and systems champion for the CareBridge Connect program. And also joined by Paul Murphy, Quality INSITE co-owner. Paul's previously in the financial advice world and heavily involved in bed placement and more recently long stay placement with the Metro South team. I myself, I've worked within the aged care industry for a while now, mainly admissions, marketing and sales processes. I've worked really closely with the social work teams across a number of different hospital networks. So I've met quite a few of you, and some of you have probably heard of the name as we float around, but really interested in how we can improve that resident patient client flow from that hospital network into the aged care world. So this discussion is really born out of that. So we're here today to build a further understanding of what the current picture is for the hospital network and with the aged care providers. I know in an hour and a half we are not going to solve every issue that's presented today, and we might not even highlight all the issues that are coming forward, but we're certainly hoping to continue the conversation, and we acknowledge that there's other forums and discussions that have taken place, but we feel it's important to continue to want to raise the bar in terms of presenting options for elderly Queenslanders that need care. So during my time in the industry, I've spent a vast amount of time dealing with the aged care entry process, roadblocks and some solutions. I've acted as an advocate for both the hospital social work team when we're looking at a resident coming into care, and then also had to push back when patient information or the complexity of care is a barrier to entry. So pretty confident I understand that process well. Just before I introduce our first speaker, which will be Fiona, so put you on the spot, Fiona Trad, we want to really make sure that we've got a good understanding of what the current position and have some suggested pathways and solutions moving forward. So we're welcoming any input that any delegate wishes to put forward. So those on camera can speak. Those that are joining us through the other live stream network can use the live chat function, and Lisa will be monitoring that. I'd also like to recognise especially Dr. Terry Nash, who's given up a bit of time to join us. We'd really welcome your input, Terry, and Liz Whiting, I see you're here as well. Both your input and your experience around this aged care journey, you would have different angles from that, so please feel free to jump in. Fiona, I'd like to welcome Fiona Trad. She's going to be the first cab off the rank to talk about the hospital position and what she's seen in her position as advanced social worker and clinical team leader, internal, the Pathways team and long stay. Fiona, welcome. Are you able to share your screen? I know you've got a presentation to talk through. Yep. Over to you, Fiona. I think you might be still on mute. Yep.
Sorry, Brad, just working out the technicalities of this new
That's
system.
good, more than fine.
Is that up now?
Yes, we can see that. Thank you. Yeah.
Wonderful. All right. So firstly, thank you, Brad, for having me present today. So for those who don't know me, my name's Fiona Trad and I'm an advanced social worker working in Queensland Health. I have been at Queensland Health for the last 15 years and working in the discharge to RACF space for most of that time. My current role is as clinical team leader here at the PA, and I work with the team primarily responsible for most of the discharges to aged care from the PA, but also oversee the flow of patients across the PA to aged care facilities. So today I'll be presenting from the hospital and specifically from the PA perspective and trying to give some context as to our experience, some of the frameworks we work within, and some of the trends that we've noted in that discharge to RACF space over recent years. Okay, so I thought I'd start with some of the key concepts that we work within at the hospital, just to put everyone into context. So patient flow is a key concept that we work within in the hospital system, and that refers to movement of patients through the care setting. So that includes the entire patient journey, so from entry and through ED, then through their inpatient stay, and then through towards discharge back into the community. And so as everyone would be aware, poor patient flow can have detrimental effects on the health outcomes of people, but it also leads to access blocks and care delays in the broader hospital system. And that's when we hear the concepts such as hospital ramping, ED ramping, ambulance ramping, all of that sort of stuff is often as a result of some back-end blockages and discharge delays. The other concept we work within in this space is long stay. So that refers to patients who are medically and clinically ready for discharge, but who are unable to do so due to some sort of external barrier. So our patients who are being medically cleared but are awaiting an aged care bed fall into that criteria. Some of the adverse impacts that we find with lengthy hospital stay include cognitive, physical and psychological impacts. So things like deconditioning, exposure to hospital-acquired illnesses, and that's certainly become more of an issue in the age of COVID. Decline in mental health, so people certainly become quite down or anxious when they're in hospital for long term, but we also find people become increasingly anxious for discharge the longer they stay in. So that's when we have bed offers and people declining those bed offers because they feel quite safe and supported within the hospital system. I thought I'd just really quickly touch on some of the data and trends that we've seen over recent years. So at the Metro South as a whole, and when I say Metro South as a whole, I'm referring to the PA, to QE2 and Redlands, and also Logan and Beaudesert. So if we're looking at the data from August last year to February this year, we had a total of 600 patients discharged to an aged care facility in that time. At any one time, across Metro South, we'll have about 150 long stay patients. 100 of those, so two-thirds of those are waiting for an aged care bed. And that's enough to fill a small hospital, probably the size of, say, Redlands. And then at the PA alone, we have 30 people waiting for an aged care bed at any one time. So that's enough to fill one of our wards and beyond. So some of the trends that we've seen over recent years, so certainly increased activity in the aged care space, and I'm sure everyone's feeling that. Lower supply, and that is leading to longer lengths of stay for people in hospital. So over the last 3 years, the PA has discharged approximately a person a day to either an aged care facility or interim care. We've had approximately 100 additional people enter the pathway than we did the 5 years previous. And the average time on the RACF pathway, so that's from when they're medically cleared to the day that they leave, went from, in 2022, 20 days, 2023 we had 23 days, and then it spiked up to 32 days last year. And you can see from this graph over here, 2022, 2023, fairly linear, but you can see these spikes in 2024 where people were waiting an average of 40 to 50 days at times in certain months, and we go beyond 100 days for some of our really difficult to place patients. So if we quantify that, in 2024, we had a total of approximately 11,168 hospital bed days at the PA that were taken for patients waiting for an aged care bed in the community. So that's equivalent to 3,723 three-day care journeys. So, sorry, there we go. The other trend we have noticed more recently is an increase in breakdown of care at facilities. So you can see by the data here, the trend line is certainly increasing. And certainly over 2023, 2024, we had quite a number of breakdown in cares at facilities. So the main reason for that is behaviours of concern or sexual disinhibition. So that certainly is the main reason for care breakdown. We saw a spike in failed placements, and that was noted post-2022, the end of 2022, when the SIRS, or the Serious Incident Response Scheme, commenced. Mental health and suicide ideation or disruptive behaviours is another reason for breakdown in care. That's particularly for those who require a higher level of emotional input or regulation. We've seen restricted practice consent changes end of 2022, 2023. So there just seemed to be, from our point of view, a lack of clarity in community around the rollout to those changes. And that did lead to multiple occurrences of breakdown in care in community. And then we have things like financial complexities where people are refusing to pay, people who use excessive alcohol in communities and have in facilities and have behaviours of concern, and also family or patient reasons where they don't want to accept a permanent bed offer or are unhappy to return to facilities, all of them leading to breakdown of care in the facility that they were in. This data is referring to both respite and permanent breakdown in cares, but there's certainly been a spike in permanent breakdowns as well. Okay, so when we look at the barriers to finding an aged care placement for people, certainly the changes in the landscape have been quite profound over the last few years. We've had the demand versus supply shift, so there's certainly a tight market with most facilities now waitlisted, and there's a definite lack of supply in the memory support secure unit side of things. And that obviously has a flow-on effect to people with behaviours of concern or complex care needs. Certainly less flow for people with behaviours of concern from hospital back into community. And that was particularly noted after the SIRS and restrictive practice changes that we discussed in the last slide. Respite over permanent transition. So there seems to be an increasing propensity to accept patients for respite over permanent, and that is increasingly leading to people ending up back in hospital at the end of their respite stay without a permanent offer. And then we have our financial constraints. So there's definitely an increasing perception on the hospital side of things that people who are self-funded are easier to place than those who are fully funded or requiring a concessional bed. And so those patients are certainly finding a significant delay to discharge as well. Okay, so a few other observations from the hospital's perspective over recent years. We have noted just the networks and relationships that were in place seem to have broken down somewhat with some aged care facilities over recent years. Some facilities are going towards centralised systems without key people or key hospital contacts, and some facilities are actually foregoing liaison with hospital clinicians altogether in favour of just going through families or the patient themselves, which I can absolutely understand, but we do play a key part in that discharge and hold a lot of the information that's essential to that transition being as supported as possible. Where there's a breakdown in care, often patients will come to hospital without any clinical handover or care details, and we do find it difficult at times to contact key people that know the care needs of the person. And we are losing a lot of our escalation pathways that we had when there is a breakdown of care, so we can speak to the people that can actually make really clear decisions as quickly as possible. And then for the EOI or application process, there seems to be a reduced opportunity for open and constructive dialogue around some of those applications. There's definitely a delay in outcome for EOIs, or at times we don't actually get an outcome. Sometimes there's minimal or no feedback around reasons for clinical decline, and that's always really helpful for us to know, because then we can go back and review the evidence and make sure we're giving context around some of the information that we're giving. And also some facilities are certainly voicing some frustrations to my clinicians when we're making inquiries as to the status of EOIs. And I completely understand you're getting many, many calls from many, many people on any given day. But it just means those communication pathways have broken down a little bit. Some of the strategies that we're trying to implement at the PA hospital to address some of these things, certainly collaborative focus. So we do appreciate forming and maintaining networks and relationships with our key industry stakeholders where possible. We have our outreach and transitional supports. We're looking at our dementia delirium team and the nurse navigator that can provide outreach support into facilities. We also have our wonderful care pack team that do a lot of work going into facilities to try and work with residents within their home. And also avoid, where possible, people having to come back to hospital and break down in care. And then we have the evidence that we're supplying. We always do try and give behaviour support plans for those people that have behaviours of concern, just to make that transition a little bit easier. And we are at the moment working on our nursing care plans to make them a little bit more robust and a little bit more fit for purpose, and hopefully rolling out those new nursing care plans in the next couple of weeks. And then finally, we do try and remain as informed and connected with what's going on in community as possible, and also update our key health stakeholders around what's going on and the reason for discharge delays, because I think obviously these issues are broader than any one person. And I think we all need to come together just to try and find some solutions that will be in the best interest of the people that we work with. So I think I'm at about time, so I'll hand over to you, Brad, but thank you for listening to me today, and happy to answer any questions as the day goes on.
No, thank you, Fiona, and I really do thank you for putting that presentation together. We've got some delegates that are online that will hopefully type some questions in. We've got some people that are on camera that are certainly able to ask a question as well. In terms of your experience with that patient flow, and we've discussed this a couple of times, like previous years, you'd had a lot of people knocking on the door looking for a patient to enter a bed. Now that's becoming more difficult as it moves through. Where are the big groups of people? Like you did explain, people needing secure unit as one, but where are the big clumps of people that you're seeing are becoming a real blockage and potentially worrying you into the future?
Definitely are people with behaviours of concern or complex mental health seems to be a cohort of people at the moment that are very difficult to find a suitable place for. Our concessional or fully funded people increasingly are finding it difficult to find a bed. And we do have currently facilities coming to us and saying that they are only accepting people who are going to be fee paying or have that co-contribution. So they're certainly pretty large cohort of people as well. And then we have our smaller cohort of people that need fairly complex clinical support needs. So people with trachees certainly are a difficult cohort to place. People who are smoking or drinking excessively are certainly a cohort that are difficult to place as well. Really anyone that has anything a little bit more complex or kind of off the cusp, needing a little bit more support in that transition and through their care is going to be difficult to place at the moment.
Yeah, and we've got, I know we've got a couple of operations managers on camera if they're brave enough to ask a couple of questions, but there's, I guess from my point of view in the sales space, and when I am joined by other colleagues on here that work in that sales space, the assessment criteria and the triaging of that resident coming through is becoming more complex, and post July 1st is even more complex again. When we look at considering people with behaviours and the low means and all that sort of stuff, what are some of the things that you've discussed internally that may help move the needle in terms of, let's talk about complex care. What additional support mechanisms may be in place that the group are not aware of in terms of training, equipment, dedicated staff, all that sort of stuff?
Really good question, Brad. So we do have teams. So dialysis is a really good example for people that need dialysis on site, the peritoneal dialysis. We do have teams that can go out and train people in community and facilities to make sure that they are able to manage that. Trachea care is training that we can provide. We do have our wonderful care pack team that can provide ongoing support as well. And so really it comes down to if there is any clinical need that's too complex, if we have an ability to train staff to be able to work with that, we certainly will do that. I think the difficulty is we're not often getting feedback as to why people are declined. And if we know that, sometimes we can either put context into play around the reasons for decline and how we're managing it, or we can put the resources in to make sure that the facilities feel supported with taking on that person's care.
Yeah, excellent. And we've got a statement up there, anyone on medications that could be considered chemical restraint. We're fortunate enough, and I'll bring Frances McQuillan into the discussion. I'll do an intro on you, Frances, shortly, but you've got the added benefit of working for the regulator as well as working within the sector, and chemical restraint and controlling someone's behaviour via medication is a bit of an issue for the department through overuse. But what are some of the issues you see around that, Frances?
Thanks, Brad. To me, they're not really issues. I think there's collaboration aspects that we miss out on. I think that Fiona and her team provide enough information for us to be proactive in being able to identify these items and being able to have those medication charts addressed or diagnosis updated so that that transition can be a lot smoother. I think if there is a gap there, then having that engagement with your GP automatically can also allow that to be a factor to allow that admission to happen freely. I was on site in the PA last week with Fiona's colleague Sam, and we were looking at one of the consumers that had been there for the last 8 months. And what I see coming through is not the complexity of healthcare. I think there's a fear factor in relation to the unknown, and mental health is definitely an area that individuals are fearing because they don't know enough. Yes, we have individuals who have dementia, and we need that chemical support in supporting residents live the best life. However, the mental health aspect is where the fear factor is with some of the, I would say, the RNs coming through. They don't have enough knowledge, education, and especially with a number of new grads coming through as well. You see that type of balance where managers are looking at their skill mix in relation to the residents coming through, and it doesn't always equate. When the assessors come through and staff can't talk through restraints in any form, then that is where that concern is. But to me, it could be very strategic. I know that the likes of Care Pact are out there and they're providing education, they're providing in that complex clinical care, but there are other elements that we just need to fine tune and find the right audience for different resident needs as well.
Thanks, mate. We've got a statement from Hannah Carroll from Vicente. Much of the risk for us, Vicente, isn't clinical care, but care of the complex resident. It's the impact to others, the fear, the social withdrawal, etc. And it's a really good point, because it's probably, if I look at from my point of view and having to re-explain back to Fiona's team, for example, it's quite often not the ability to look after the individual, it's the impact of that individual upon the rest of the resident cohort. And what are the strategies that could be in place to mitigate that impact? And there is a fear around impacting on other residents to live their life in care. Does anyone in the group want to comment around that piece? Is it relevant to you, Frances or Helen? Yep.
Yeah, look, I think personally, a lot of the issues that providers are facing at the moment is ageing stock in their buildings, and the increased acuity of the residents that are coming through with these mental health and dementia diagnosis. So, you know, they're scrambling to make sure the environment is appropriate and people have that space to be able to find that privacy. And it's something that I'm sure we're all working through. Other than that, it really is a big challenge, because the residents they have different expectations to reality, I guess. And so they don't have that education behind them either. We do at Western Mission Queensland, we do regular education sessions to our residents around dementia and what is dementia, and how to deal with it themselves, not just the staff, because that's what we get back from our resident advisory committee meetings as well.
Yeah, excellent. Thank you, Helen. Anyone, like I know Fiona, you seem to be the sole representative on camera of hospitals, but we do have Terry to back you up. Being furnished with the information around not only the complex care needs of somebody, but also their ability to impact upon other residents. Are there strategies like pre-admission that could be looked at as a different angle to bringing this resident on board? I mean, we can add the training for help, but how can we help that resident transition into care without impacting on others?
Good question, Brad.
Well,
I think, look, it is complex, and we see it all the time. We certainly deal with it on the hospital grounds all the time as well. The resident mix or the patient mix is an issue. What we do have is a an extremely experienced team here at the PA that do put together fairly clear behaviour support plans when necessary for patients where there are behaviours that should then transition through to an aged care facility. So those behaviour support plans have been developed generally in an environment that may be somewhat similar to a memory support unit, but also developed in the context of being in a ward type environment with other people. So I guess that's one thing that we can offer. We can certainly offer nurse navigator support on discharge. That nurse navigator usually knows the patient from the hospital and can help with that transition through. And I know DSA is actually putting in place some really good supports around discharge and entry into facilities that help in that transition for people with behaviours of concern as well. So there are a few little things there that we do have available to us at the moment.
Yeah, excellent. Just a quick message. I've got some messages that some of the chat function's not working. Some people are still trying to join. Bear with us. Lisa's working on it now to get you in. Chat's sort of working in some respects, but it could be just your local internet connection that's playing up as well. Just coming back to that, thanks, Fiona. Just coming back to that, like one of the fears that the aged care network has got, and sorry for speaking on behalf of aged care, but I know it's a relevant issue, is the failed placement piece. And I know, Terry, you've sort of been outspoken about this a little bit as well in terms of solution building, but it is a real fear to have a resident join a home and then find, for whatever reason, that resident has to be discharged from the service due to behaviours, complexity of care, etc. And then they find themselves back at the hospital. And most often cases, they end up a long stay resident or patient of that facility. What are some of the other preemptive things that we can do as an aged care network to help mitigate that risk beyond what we're doing now?
G'day, it's Terry from Impact, and I just want to acknowledge, thank you, that's a very complex thing for us to talk about, and please interrupt me as we go. And I can see Lisa is able to contribute the text, and Lisa's really, for me, my go-to expert around this. But I will say that what I think we could all share, acknowledge, I guess, our shared experiences here, which is in the first instance, the complexity of the resident first coming into aged care year on year is increasing. We can see that through the funding instrument. We can see that through just measures of multi-morbidity. People are entering aged care at a later stage in their experience of dementia. We're seeing people then come to hospital, and Aisling, hey Aisling, and the people that are coming to hospital are coming at a later stage in their disease as well, because we've had people living at home with home supports for longer. So the cohort of people that are coming to hospital to be selected for residential aged care are a more complex cohort compared to 10 or 20 years ago. I think as well, when someone's acutely unwell, which is often the reason they come into hospital, not just because they're needing accommodation, they've had an acute illness or injury, that is a very difficult time to adequately define a full behaviour support plan for someone. You do need the dust to settle on the acute, emergent or clinical event. And sometimes that can be days, weeks, or even months before that settles and a behaviour support plan makes sense. But in terms of Hannah's commentary, and I think really this is the key, is how do we as a network, how do we as a group reduce the level of fear around someone's responsive behaviours? Is this something that we need to sort of, improve the conversation, improve the language we're using? Yes, we sort of, should we move from behaviours of concern towards responsive behaviours as a type of language that shifts our focus more to what is the unmet care need? Is that a good trend that we all want to embrace? That's some of the things I think about, but I do want to just, I guess, acknowledge that with an advancing timeline, with more and more home care packages and people being cared for at home, residential aged care is a place where people with far more complex care needs will be concentrated. There will be more people co-located, co-living with other folks who have more complex either cognitive care needs or they have other nursing care needs. This is a reality of the trends that we're experiencing. It is becoming, in a sense, a specialist nursing skill set to be able to work in residential aged care. To manage residential aged care, you are a specialist type of manager with a certain set of skills. And I think that whenever that's the case in healthcare, we have to rely very heavily, I think, on networks and each other to sort of come up with novel solutions and share our frustrations, but then share some of the things that actually might work. So I think that in the first way to think about this is we need these forums regularly where senior people cut across different parts of the healthcare system, cut across different employers, and we can actually talk about what's challenging, what we've tried, what we've failed, what we've worked, what did work. Because I definitely don't think this is a space where we're going to find a one-size-fits-all. I think we'll have some wins with little projects here and there, and we'll have little ideas that we might get some little cut-off little cohorts here and there that might work. I think Fiona's spoken beautifully about how in Metro South Health, we do need to optimise how we use our services like nurse navigators. How are we using our services that touch into aged care, for example, specialist outpatient services, and providing those services on site, because that builds the confidence and trust, I think, to manage residents with the proper support from the specialist outreach services in the aged care facility. I think that goes a really long way to making sure that there's that skill sharing on site, no longer ending up in a situation where the resident is taken away from the facility to get specialist care. The staff in the facility get to experience what it seems to be to have the resident get, specialist-led care in the facility, working with the GP. So doing those sorts of things, I think, as a Metro South Health entity, and certainly stuff that we're working on to get that more equitable and better across the sector, is, I think, something we need to do at our end and keep looking at ways to improve that. And I think, Kim, your point is so well taken. If we're, we do need to see aged care nursing, aged care clinical management as a very specialist skill set. You are looking after an incredibly complex, multi-morbid, very, very specific group of folks who have needs that are not easy to solve. It's not easy to solve the problem of someone who's aging, whose behaviours include sexually inappropriate approaches to other residents. It's not easy to manage someone who can't, behave or respond in a way that's non-violent. These are really hard things. So yeah, I think there's a lot to it. I'm sorry I can't refine it into an easy point, because I do think there's a lot we need to be working at each side of the industry.
Yeah, I agree, Terry. It's certainly not a question that would be answered in a 5-minute flurry, but it's something that definitely needs to be expanded upon. We are getting loads of comments coming through, and thanks for answering Kim's. I noticed the second question around getting doctors wanting to service providers weekly. It is my experience personally, and I know a number of providers have seen this as well, as getting GPs wanting to engage in the service. And I know it's one of the barriers to admissions at times, to make sure that we've got GPs on board to help in that transition to care. I mean, they make up part of that team that looks after that resident. Now, there is no easy answers on doctors. I'm not expecting anyone to have a silver bullet, but it is certainly something that is preventing quick admissions, is the availability of GPs in the area. Does anyone want to add additional comment to what Kim said there?
I wanted to say around, I put a comment in around psych geriatricians as well. In Metro South, we just had a big push last year on telehealth. There's my comment. I think that we could potentially stop readmissions if we had more timely access to the psych geriatricians. And of course, that's also resourcing, I would assume, trying to get people to see our residents that are in crisis.
Yeah, definitely. Does anyone want to comment to that?
I'll jump in, Brad. Sorry, I've joined a little late on camera, everybody. I'm Hannah from Vicente. We are having a critical problem in sourcing GPs across our homes in Metro South and one in Metro North. The campaign's really been led by our nurse practitioner all the way up to Brisbane South, Brisbane North, PHN, in terms of advocating for particularly our homes out in the Redlands. This then, creates a snowball effect of requiring after-hours GPs, referrals to Care Pact and to Radar, and then burden on our existing GPs. So a lot of our homes we're struggling to find GPs who'll take even 10 residents, but I absolutely agree with the psychogeriatricians is something, is a role our GPs are telling me that they just cannot access.
Yeah, great. Thanks. And while we got you, Hannah, because you are on annual leave and you're joining us, and I'm thankful for that after working very hard. I just want to ask you a couple of questions around your experiences in, particularly in reference to risk. So looking at the assessment criteria of someone coming into care, what are some of the key indicators that your team are looking for in terms of risk of someone coming into care that the hospital network may not be aware of, or is something different that they didn't think of?
We're in a unique position of being Metro and supported by the likes of Fiona and Terry and the guys at Radar Royal and everything. So we have the infrastructure internally. All of our facility managers are experienced clinical registered nurses. We've got a nurse practitioner on staff. So we are well placed to consider risk. One of the things we put together to really take our people through the decision-making process was a complex case risk assessment, which I have shared with Terry before, just to give some breadth to what providers actually do have to consider when they're talking through or considering a complex patient in regards to risk. So our risk matrix considers risk indicators for the prospective resident, from anything from physical aggression to other residents, patients in hospitals, staff or loved ones, all the way down to complex technical nursing, which is less of a risk for us. We have the expertise. However, there are some things, particularly with the trachees that we have, with peritoneal dialysis that we look after. Then we apply those risk indicators to how it affects us as a business in terms of our corporate risk areas: breach of duty of care, regulatory compliance, human resource management, lots of things like that. Then we start looking at, well, what's the likelihood of these negative events occurring? So the hospital information is very important. Yes, when you're talking about specials and high dependence units or high visual units, or security has been called, things like that is an alert to us, but not a deal breaker, because we want to work through the risk matrix. And then we look at what the potential consequences of this negative event happening. And for us, back to what Helen said, we have a few homes with aging stock, so it is absolutely a key thing for us. We've got homes with one home with communal bathrooms, others with shared rooms. So we look through insignificant all the way up to catastrophic, and most of it we're looking at damage to buildings, impact to others, impact to staff, things like that. And then we really want to look at risk reduction and treatment. So focusing on the person overall, what can we possibly do to help this person transition in the best way possible? And then we work through with our managers what are all the concepts or what are all the ingredients to kind of set up for success. And sometimes when we do know the triggers, we do know the history, it might be a long stay patient, we really consider it as a high risk group. And we may have to say, no, look, this is what we can't take on. We would communicate that back through the network. Otherwise, we put those treatments in place and hope to manage.
Yeah, and just one other question, Hannah, while I've got you. We've seen the mandating of care minutes come through, and it has caused issues in making sure we've got the right staff attracted. Is there considerations now around what's the staffing cohort, what's the care minutes impact upon a new entrant coming into care? Are you seeing that starting to be an issue now?
At some homes, yes. We never wanted to be a provider that had to balance our care minutes with who we'd take on, because we wanted, service the community. But there are some times now we have to consider staffing in regard to acuity, particularly at homes that don't have the either infrastructure or public transport networks and things like that for our smaller bayside homes. But the recent change in ANAC to really give some more support to those with a cognitive impairment has been helpful.
Yeah, great. Thank you, Hannah, and thanks again for jumping on during your annual leave. It's always appreciated.
Just for you, Brad.
Thanks. I'd like to call upon Frances McQuillan. So Frances obviously answered a couple of questions for us before, but Frances is the operations manager for TRICARE. Frances, as I said before, you've been in that unique position where you've worked in as a facility manager, you're now operations manager, you work with the regulator in doing compliance. So I think you're well positioned to sort of talk to the impact of compliance and the effect on how that entry is on people coming into care. What do you think are some of the issues that we have when incorrect information is presented upon admission, and what are the fears of the provider then of bringing someone on board which may affect their compliance status?
The communication piece is always key. When you have wrong information going through, and the assessors are very diligent in ensuring that contingency of care and that what has been handed over from the hospital has been maintained, that visibility and documentation, the charting, the outcome on the resident, the engagement with the EPOA, a lot of that is factored into an assessor reviewing your admission. They will look at how that journey started. They will look at those pieces of risk. They will see how you're mitigating that risk you've identified, as well as who have you collaborated with. We all know that we have referral processes in place. It's the timely manner of it, the impact it has on an individual when we haven't met that time frame, but also what we have done to ease any pain or any outcome on a resident while we're waiting that referral coming through as well. I know that a lot of PHNs and hospitals are very engaging. They will give as much information as possible, and I think that asking the question is always the key thing. Just not, if you have an item there that has a question mark, ask your social worker, ask your GPs, ask your specialism, your DSA for clarity on that there, so that you can put those interventions in place so that you can get the support network around. BSPs are a big thing that we have implemented, but do they correlate with all those other care plans that feed into it as well? That misinformation leads to the non-compliance risk as well.
Yeah, and Liz has just raised a point, Frances, while you were talking, is about needing to look at transitional complex patients. We were, from a Quality INSITE point of view, we were fortunate enough to be involved in a long stay discussion with Redlands Hospital and Blue Care, which is a really fruitful discussion where all the key contributors to that patient's care were involved, and key contributors from Blue Care were involved. And there was a really fruitful discussion in and around the good and the bad, the ugly of that patient's needs and wants and care. Francis, from that discussion there, and I'm sure anyone else can jump into this, I mean, putting aside half an hour to an hour to have that type of group discussion, to me, is more valuable than worrying about a number of emails going backwards and forwards and potentially wasting weeks in ignored phone calls and ignored emails. Do you see from your point of view that process working better than not?
I think that process would save time down the line. I think if we have that FaceTime and take the half an hour, 45 minutes that we need, it will allow the admission to be a lot more straightforward, but also those follow-ups, those, let's call them commission complaints, all those areas of risk of even reports through to the ombudsman, etc. They're the elements that we overlook by not providing time for these admissions to have a straight pathway through, and then we end up having to react to complaints and families and residents and external bodies as well. So to me, it's a very, very straightforward suggestion, and I think that we give the time and continue with that collaboration. And to me, if you have those regularly, you actually know what the expectation is on both sides.
Yeah, and I think Karen's made a good point on that. The facility managers appreciate the honest information, but also I know talking to that hospital team post that meeting, they appreciated the candid responses, and they also saw the can-do attitude of that facility team, which in my experience, majority of facility teams have a can-do attitude towards getting someone in. It's when there's potential misrepresentation or something missing in the information that creates a barrier or a mistrust, to put it more plainly, if they transition to care.
So one other thing, Brad, I know that we talked about that pre-admission conversation, but yeah, I would say that a post-admission conversation as well would also be beneficial, not just for Fiona and her team, but for the facility to see what we could do better, and if there were any surprises that they could learn from as well.
Yeah, and that's a great point. Post that, there was a weekly follow-up on that particular long stay resident / patient. That information was shared continually, and they found out there was more issues in the background that probably could have been resolved at the hospital level, and stuff that the home could be doing as well. So really valuable process, and something that I think could be easily bridged. Whilst we're in this discussion, I'd like to bring in Nick McDonald. So Nick is the owner of Prestige In-Home Care. Nick's a clinician, so he's certainly got the experience in the background and has operated a business for a long time in the sector. We've asked Nick to come on board to sort of bring that home care perspective on what is going on, because I actually think, in the crystal ball sense, that home care is going to occupy a gap, particularly for low means or fully supported residents, and potentially those residents. I know Dr. Terry Nash was talking about those people that are coming in later and more complex care, but I think there's a period of time before that some people have entered into resi care, that home care is definitely going to take up that slack. So in my experience talking to social workers, there's a bit of a disconnect in home care. So Nick, welcome. Thanks for spending a bit of time with us. Now, a lot of yours is more around, how do we get your service provision more known in the hospital network? Is probably the biggest thing that I see.
Yeah, thanks, Brad. And it's been very interesting listening. My whole career has been more on the home care side, and obviously we work very closely with both the acute sector and also residential care, but understanding some of the challenges that you're all facing at the minute, it was a bit of an eye-opener for me, and just interesting to hear, I guess, some of the barriers to getting those people home. You know, we started our business 20 years ago with a view to making sure people could stay at home as long as they chose to, and get the care they need in their own home. And picturing someone in a hospital for 8 months, it's got to be a solution, I would have thought. But Yeah, I think your question, Brad, is a good one. You know, one of our biggest challenges is, you know, we sometimes joke about, I guess, what we do as the world's best kept secret. You know, a lot of people just either don't know about home care at all, and obviously the people in this room, you know, would be a different sort of cohort with a greater level of understanding. But even so, I'm constantly amazed that the people I speak to, even in the discharge planning teams at various hospitals we work with, that kind of had no idea about what services can be delivered at home. So I think raising an awareness, you know, within the, you know, the acute sector about what sort of care people can have at home is really important, and it's constantly evolving and constantly changing. And our sector itself has also gone through a tremendous amount of change, and so you know, it's just something that's got to, you know, we've got to find a way for that information flow to be constant and updated. I think there's also in our experience been there's a lot of complexities. As you said, Paul's background more in financial planning, he would be more expert than I, but there's extraordinary complexities in how care is funded, and what people's co-contributions are, but also, you know, the myriad of different funding options to help, you know, sometimes cobble together enough capacity for people to get the care that they really need to stay safe at home. And also, you know, we've got enormous segment of the people that we support just fund their care themselves. You know, that's where they want to be. Perhaps the government funding isn't sufficient, or it helps, but the care needs far outstrip what the government's prepared to fund for care in the home. And so I think, again, being creative and understanding some of those options helps with thinking about discharging home, you know, for some, you know, patients, as opposed to thinking, okay, they have to go into a residential facility. I mean, an example is we've got some clients that we look after who have nurses in their home, and you were very generous saying I'm a clinician, Brad. I'm technically still a nurse, but I don't dare step into the client's home as a nurse these days. But we've got clients that have nursing 24 hours a day, and obviously, you know, there are some other acute services that are super valuable and relevant in an acute hospital, but you don't get a nurse sitting by your bedside 24 hours a day in a hospital, and certainly not in a residential care facility. So I think an understanding around what can be done at home is a big part of that solution around ensuring that people whose jobs revolve around getting people well in an acute setting and then getting them back to wherever they best belong and where they want to be with the supports that they need to ensure that they are well and don't bounce back in. You know, I think that's part of the challenge. So happy to talk all day about in-home care, but it's only a small piece of this puzzle, I think. But very happy if people have specific questions or things that I might be able to contribute.
Yeah, Nick, I've got one other one there for you, and it's probably more around, again, the processes of risk assessment that your team undertakes for an holistic assessment for someone to go in, because it's more than just clinical needs. As you pointed out, there might be some other daily living support that takes place. Do you want to just speak to the process your team does for an assessment criteria?
Yeah, sure. And it was, again, another sort of interesting element hearing some of the previous talks, people speaking about the challenges of the impact on behaviours, etc., on other residents, because often our clients are the only ones in their home, or they may have a husband or wife. And so some of those behaviours, I picture our clients and think, yeah, that would not work well in a more social setting or where there are other people in the home. So our assessment sort of lens, if you like, is quite different, and it's usually anchored to, you know, first and foremost, kind of clinical acuity or how safely can we deliver the care. Obviously, the homes for us are the workplace, and so the health and safety element and ensuring that the appropriate equipment and all of that sort of stuff is in place prior to commencing care at home. But we have a whole team who are designated to helping people with inquiries about particular individuals, whether that's a family member ringing us themselves, a GP calling, or someone from within an acute hospital that sort of says, hey, we've got this person coming home, this is their situation, is it something that you guys could support with? So that's sort of the first part. And then we have case managers who are usually nurses that, will do a pretty thorough sort of care planning and assessment process. Again, more around the services that are required and how we're going to deliver them safely. But there's also sort of a psychosocial layer that wraps around that. And as you can imagine, in someone's home, getting the right sort of staff there is not just around technical capability. It's also someone that's going to fit with that particular individual and their home environment. So there's a fair bit of it that sort of wraps around that. And a lot of our clients are, quite unwell and need high levels of care and have limited capacity to play their part in that process. And so it often is, a husband, a wife, a son, daughter, someone that's involved in ensuring that that person is well looked after, that steps in and plays that part of the assessment process.
Yeah, thanks, Nick. And really, like, listening to you speak, and thank you for your input on that. It's clear to me that with the group that we've got here online now and those listening in and potentially across our whole network, that we need to develop real true partnerships where the home care provider is probably the early interceptor of someone declining. The hospital is obviously another junction point where someone then potentially could end up in residential aged care. But I guess where the opportunity for us, and it probably is the silver bullet that's going to take a long time to sort out, is how do we get that flow of someone who's in home care for a number of years that has declined to the state where they need residential aged care. Thank you, Terry, for joining us. I noticed you've got to jump off. Thanks again. Where they then need residential aged care, they may have bounced into the hospital network, but the home care provision and the residential aged care provision, I've already started working through that bridging, because the idea is not to have this person become a long stay patient in hospital. Is where I think the real true success story would be in that. Nick, crystal balling it, I know they've released, or they're going to release a heap of new packages. How do you see that process flowing through in your eyes moving forward?
Yeah, there's I think there's about 300,000 people currently on a government-funded aged care package. There's something like 80,000 on the wait list at the moment. People are waiting 6, 12, 18 months, once they're assessed as needing it to accessing the funds or the package. So there's sort of 80,000 waiting, and the government has committed to releasing just over 100,000 packages from sort of July this year till July 27. So, the goal is to flood the market with packages to ensure that no one really has to wait too long. How that's going to play out will remain to be seen. I mean, our business is doing really well, but I still hear from some other peers that they're having challenges around workforce. So it's great if another 100,000 people have funding to get care at home, but somebody's got to deliver the care. So I think the workforce element is still an enormous challenge, in certain sections of the industry. But I do think it's going to, create a greater opportunity for people to get the care they need at home. And it often is, as you said, Brad, we've got people right up the high end of acuity, but it's often the entry point. They're managing independently. Maybe they've been in and out of hospital a couple of times, but they're pretty much well at home. And if they can start getting some lower levels of support, as you said, it gives the opportunity for, a health services provider to start them on that journey and be there to pick up, deterioration or signs of concern that may sort of prevent any admissions into the acute sector, and to sort of continue to work with that client or their families around, do they need to move into a facility at some stage, and what would that look like, and to start those conversations early.
Yeah, I agree. Does anyone else want to make comment around that? Any of the providers that, or Fiona or Liz?
Brad, I think just very quickly, I think definitely home care is the future that we need to head towards where possible. Absolutely. And I am excited to see more home care packages coming through. I think the issue that we have in hospital is that often previously home care hasn't been a discharge option because of waits for home care packages or service providers or what have you. And so what we need is that system to be responsive, so we can have that as a tool or as an option to put in place for discharge. I think the other thing is looking at the risk assessments that we do and looking at whether there are a certain part of the population we work with that could actually go home and not into an aged care facility. And certainly that's something that we would need to work with the clinical teams around here. But unfortunately, by the time people get to hospital, they're also often at that pointy end of either a crisis or care need. So it is getting in early and maybe getting in proactively on the community side of things. So if people are kind of heading down that trajectory of aged care need, getting in quite early and making sure that happens before they get to hospital, because once they get here, it's really difficult. Families are burnt out, carers are burnt out. Often some of those behaviours are quite acute. And so it can be difficult for us to discharge back home at times. And it's always something that we'll consider first and foremost. It's the least restrictive option. Getting people home is always ideal if we can do so.
Yeah, great.
Yeah, I think that makes sense, Brad. And, the other thing that we see with home care that it's not impossible, but it's a bit more challenging in the residential aged care space is the ability to give it a go. We're often speaking to families and, there's conversation about, will this work? Is it the best solution? Should they be moving into a facility? And sometimes that is, but other times we're saying, all right, well, let's trial this for a week or a fortnight or a month, because if it doesn't work, obviously they can then transition into a residential care facility. Just although it does happen, it doesn't happen as often in reverse. And I guess my only other comment, there's absolutely an enormous segment of the population who, can't contribute much at all to their care. But I am often amazed at how much people contribute to their own care. So, when people, maybe on a wait list, you ask the question, there's often a great capacity for them to fund the care, especially if they know that there's a ceiling on it. There is a timeline. They're funding the care until the government will, get their act together and start contributing. So just another consideration I'm sure your team's already looking at anyway.
Yeah. And I guess just to add to that conversation of information, I mean, it's been estimated across the country that we need 10,000 additional residential aged care beds a year, pretty much between 8 and 10. So that would mean the Queensland market would need anywhere between 1,500 to 2,000 beds built. I know from the back of the cigarette packet assessment that I've done this year, there's probably only about 200 incremental beds coming online this year in the Queensland market, let alone just southeast Queensland, because there's some facilities closing, there's some facilities obviously new that are coming on board. So I think home care, whilst there are some challenges and there's been some really good comments come up, I think home care is going to be one of those areas that is going to have more special consideration. And that sounds weird coming from a resi aged care guy that was probably told a while ago that a home care is a competitor. I actually don't see it as a competitor. I see it as a partner in how do we bring people through, because I also experienced the other end of the chain where we're telling people, no, we can't accommodate you in the aged care facility because we're full, or the complexity of your need is too great or unable to be fulfilled here. So I'm sure others in my position have done the same thing as well. Thanks, guys, for that. Now, look, I do note that we're in the final stretches. We've had a couple of people jump off, but I've got some open forum questions that I'd love people to jump in on, and really they are pretty broad. So I haven't narrowed them down because I don't want to get too complex after our discussions. But from an aged care provider's point of view, what are the most important pieces of information to make an assessment call, do you think, in terms of assessing someone for suitability of care? Francis and Hannah, I think Helen might have jumped off.
For us, it should, a lot of 80% of it is what we already receive through different documents. I think the pointy end for us is around, I don't want to keep coming back to those responsive or change behaviours, but it's really around triggers. Sometimes behaviour support plans, I think somebody mentioned in the chat, and Terry said, X amount of time in hospital wouldn't necessarily be the environment to construct something that would be as meaningful as if they were either with another provider or had some continuity of care elsewhere. So for us, I know we debate a little bit about things, but for us, it's around risk, anything to do with risk management and safety. So anything that's already currently in the NSAFs and support plans, that's all fine for us. Any particular clinical information, we've got a really good client relations team that liaises with teams like Fiona's to get the right information. We're quite liberal when it comes to decision making, but really it's about, for us, back down to that impact to others, and how we can avoid those triggers and manage that is our main issue at the moment.
Yeah, Francis, anything to add from your point of view?
I agree with Hannah in relation to majority of information we have. Environment and resident mix are probably the two other factors that we really need to consider when we're being realistic on placing individuals. Sometimes we react and that our bed numbers might be low, and we make a commitment to something that may lead us in a spot of bother. But yeah, I agree with Hannah. It's all around that dignity of risk. It's always about the impact on the other individuals that are there as well. Yeah,
and in my experience, given that behaviours comes up a lot, and it's a very broad term that's sometimes used, that a resident's behavioural, I had an interesting discussion last week where it was more about getting a really brief or really quick Jerry report around what are the triggers that have contributed to those behaviours, and how they've been managed both in the hospital or have been managed at home before. So I think that's a really important piece of information, particularly when I would say now 7 out of 10 patients for assessment have got some sort of behaviours against their record. I don't see a lot that are very easy to manage through, unless other providers have had a different experience. Yep, great. And no one's on chat to put forward. And another one, this is probably for more of the hospital point of view. So Fiona, again, putting you on the spot as the representative, anyone on chat. What's a more satisfactory response time for a referral application? Given it's becoming more complex to refer some of these people, what in your mind is a satisfactory response time, given that yesterday is not an answer?
I was going to say as quickly as possible, Brad. Look, I guess just to put it in context, we're having to go out to 50 facilities, to up to 50, or even I think one patient needed 75 EOIs to go out before we had a facility. So we are actually going out to many facilities at the moment, and it's taking a lot of time to secure a placement. Of those, say 50, we're only getting a small handful of responses unless we really diligently follow those up. So any response at the moment is a good response for us. As far as time frame goes, look, if we don't hear back within a couple of days, we'll often have our clinical assistants following those EOIs up just to make sure. Even an email saying we've got it and it's under clinical consideration would be helpful. because otherwise we just think it's going into the ether and we just don't know what's happening with those EOIs. So I would say, look, even a response in a couple of days to say, look, we are attending to it and we will get back to you as quickly as possible. And then it comes back to the reasons for decline. If we can get that information, sometimes we can provide more context to help in that assessment process, but often we just don't get any reason. We're just told that they're clinically not suitable. So maybe a little bit more context would be helpful as well. But I do know all of your staff are under the pump as we are. So, but yeah, any information in as quick a time as possible is the short answer, Brad.
Yeah, great. And look, it is a little bit of a leading question. We've Quality Insights currently investigating a trial with Metro North and South in regards to a CareBridge Connect portal, which within that portal has the ability of visibility of referrals, and also the provider has the ability to answer quickly on a yes and no that they're reviewing, and also to be able to respond quickly within the system, which removes the needs for social workers to be on the phone and to be following up constantly via email. So we estimate that would put time back on the floor for both sides of the equation. We're in the midst of just waiting on cybersecurity sign off from that, and then hopefully we're able to make an announcement on CareBridge. But it's something that we'll be reaching out to this group with demos post this meeting to get everyone across what it looks like. But we also want that cyber sign off from Metro South in particular before that moves ahead. We are pretty much coming towards the end of the questions that I had. Does anyone in the forum group want to add any additional comments or ask any additional questions whilst we've got a couple of minutes? You all seemed plenty of information has flowed through.
Brad, probably the only comment I do want to make, and I think someone in the chat made a comment about it as well, is that we are having to place people a long, long way away from their families often. And that is having a fairly big impact on that family unit. And often we have elderly wives, partners, husbands, carers that do find it difficult to do that transport across to different facilities when it is a distance away. So I guess it's just the context at the moment is difficult. And I think the fact that there's just not enough supply in the market means that we are really strapped with what options we have for people. But yeah, it is just really complex for patients and families. And that is another, I guess, aspect where we do often have families and patients not willing to go further afield, and that negotiation process is difficult for us as well. So I just wanted to add that very quickly.
Do you think, Fiona, and this is just thinking through your comments on that, do you think there's enough information in the market for the resident family member to be informed better? They're not going to be totally informed on resi aged care or home care, but to be informed better over what takes place and what the expectations are. And do you think your team are equipped to be able to answer a lot of those questions?
Look, we try and give the information as best we can with regards to the context and the fact that we do need to cast nets wide at the moment to get a facility for some of our more complex patients, to have a facility accept someone. I think information is always good, and I think it coming from the people best able to give that information would be helpful as well. Like I said, we do try and keep up to date, but we're not working out there in the industry. We don't always know the nuances and the ins and outs of what's going on as well. So information is always good. Yeah, great. And I think that's good background for us to, as aged care providers, to make sure that we're keeping your teams as informed as we possibly can. And given that the level of change is coming up at the middle of this year, are going to have significant impact upon your resident and your family patient flow, we'll definitely be out to you with a lot more information. Great question posted by Liz. Are these questions being posed at a federal level? Again, from personal experience, we've had a number of meetings with both state and federal government representatives.
And the first half an hour of those meetings are always them arguing about who's paying for what before they start taking into account some of these things. So we're certainly trying to push that up the chain as much as we can. And even we're finding that there's a better listening to it, but still not a lot of action coming out of it. But we did, I'm not sure if the representatives for Wellways and that are on the other chat area, but we do a lot of work with Carers Gateway in New South Wales, Queensland and South Australia. And they're certainly posing these questions, raising up to their federal, authorities as well. So yes, questions have been posed. It's just how much impact are we getting from it? If there's no further comments, and I know you're all very busy people and I really appreciate your time, I'd just like to thank you all for your attendance today. We hope you found that some of the information is formal. It's probably sparked more questions than answers, and we certainly appreciate that. We would certainly love to see these forums continue and happy to facilitate or be a delegate. Look, online's great. Face-to-face is a much more fruitful, richer discussion as well, but it's very time costly. But yeah, we'd love to see that happen in the future. But I think what that's going to do, it's going to come from your endorsement and a groundswell of support for stuff like this. And as I said in the start, I also acknowledge that these sort of forums are already taking place. I'm just not sure how much of the coalface has been interacted with when it comes to those type of forums. So certainly not a political statement, but something around that it's great to see that we've got people on camera and online that are certainly taking elderly Australians' care at heart and trying to look for better solutions across that. If no one's got any final pieces, Samantha's got a comment. Oh, yeah, thank you, Samantha. But yeah, if there's any final comments, love to hear them. Otherwise, give you 13 minutes back in your day. Oh, we've got Angela with PHNs. We've got lots of different support mechanisms out there, and it's and I'm not so sure that it all goes through. So let's make sure we spread the word across all our capabilities and work in partnership. Thanks, everybody.